So RAF is an interesting protein. It is part of an important signaling pathway in cancer that controls growth and proliferation. It sits just downstream of another key protein in lung cancer called KRAS. The RAF proteins, there are actually several of them. One of the ones that is sometimes mutated or altered in lung cancer is a protein called BRAF. It's actually fairly rare in lung cancer. Maybe 2% of all adenocarcinomas of the lung have a mutation in BRAF. Much more common in other diseases like melanoma. But in those lung cancers in which BRAF is mutant, it is an important driver of the cancer. It's an important driver of cancer growth. And it turns out there are selective inhibitors of RAF that were initially developed for melanoma, but that are now being applied in this small subsegment of lung cancer. So those patients, 1 out of 50 who have a BRAF mutation, turn out to be highly likely to respond to BRAF targeted inhibitors. These are drugs that come in a pill form, tend to have less side effects than your typical chemotherapy drugs, and are, again, quite effective in shrinking cancers that are driven by BRAF. More recently, there's been a discovery that very rarely, there's mutations also in another RAF family member called ARAF. This is the work of David Carbone. A very interesting paper that's just coming out showing that protein can also be mutated, and when it is, it's an important driver as well. So these are two of what we would call driver mutations in lung cancer. These are alterations that occur in the development of cancer that we think are particularly important in driving the cancer's growth. And if we can successfully inhibit those, we can get nice responses. One of the things that's limited the development of targeted inhibitors for lung cancer, and the same is going to be true for the RAF inhibitors, is that although these agents work tremendously well initially at shrinking these cancers, there is acquired resistance. These tumors can become resistant to the RAF inhibitors. And we've been interested in what are the mechanisms by which these tumors become resistant and what to do about it. So how to treat resistance in the context of, say, a BRAF mutation that's become, a BRAF-driven tumor that's become resistant to targeted therapy. I think we can learn a lot both from our experience in lung cancer with other driver mutations and from melanoma, where we have a lot of data on acquired resistance specifically to the BRAF inhibitors. One pathway that gets reactivated that causes resistance to BRAF is actually the other protein I mentioned, KRAS, which sits just upstream of BRAF in a lung cancer signaling pathway. In melanoma, a different RAS protein called NRAS becomes mutated, leading to resistance to RAF inhibitors. In lung cancer, KRAS mutations have been identified that cause resistance to BRAF inhibitors. So one strategy to try to get around the problem of acquired resistance is inhibiting multiple pathways together, using multiple drugs. That's an attractive strategy, but it also has the potential for more side effects, more toxicity. When you start to inhibit multiple growth pathways, there's the possibility of getting more toxicity from that combination. So we're still not sure what the best strategy is going to be, but we're exploring multiple possible strategies.